My name is Larry Lamont, and I'm the Vice President of Public Policy for the Immune Deficiency Foundation. And on behalf of the members of the American Plasma Users Coalition, we're very pleased to be able to produce this webinar series. A+ consists of patient organizations whose patients use and need plasma products, such as patients with primary immunodeficiency diseases, hemophilia, Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, alpha-1 antitrypsin, and idiopathic thrombocytopenic purpura. A few housekeeping items before we begin tonight's webinar is that it's scheduled for 90 minutes, which will include approximately 30 minutes of question and answer. This program is being recorded, therefore the organizer will be muting all participant lines during the presentation. The control panel on your screen can be minimized by clicking on the orange arrow to the left of the panel. Each A+ organization will be provided a downloadable media file of the webinar in its entirety, including the written materials sent earlier to you to post on the respective websites. The glossary will also be made available to each organization in a format whereby each organization can include its own logo. And please note that NHF reserves the right to approve changes and or additions to the terms included in the glossary. Please keep the glossary handy during the webinar. Hopefully you have looked over the information that was sent to you yesterday, but don't worry if you don't fully understand everything. The webinar will hopefully fill in the blanks. We will have a live question and answer session at the conclusion of tonight's presentation. However, feel free to submit questions throughout the program using the Questions tab in your control panel. The submitted questions will be answered at the conclusion of the program. However, if we see that several people have the same or similar questions on a particular slide or issue, we will attempt to answer that question right away. All questions, including those not answered in the allotted time of the webinar, will be compiled into a single document and forwarded to each participant via email. You will receive an evaluation survey of the webinar either this evening or tomorrow. It is very important to have your feedback. Please take the few minutes it takes to fill out the survey form. I want to say thank you to Michelle Rice and Marla Feinstein of NHF, Jim Romano of PSI, and Marlene Irvin of Alpha One, and of course JoAnn Volk of the Health Policy Institute of Georgetown University. With that, I'd like to turn things over to Michelle Rice to acknowledge our sponsors and describe the goals of the webinar series. Thanks for being with us tonight.
Yes, thank you, Larry. I would like to thank our sponsors for tonight's program. Our program sponsors, the lead sponsors are CSL Behring and Pfizer, with supporting sponsors Accredo, Baxter, Bayer Healthcare, Grifols, and Novo Nordisk. Without their assistance, this program would not be possible. And for the objectives of this series is to begin developing, is to help advocates understand how the Affordable Care Act is going to affect their care, and help advocates understand what the ACA will mean for healthcare in their respective states. And it's to arm you all with the tools that you need to ensure that ACA implementation in your state meets the needs of the patient groups that you serve. At this point, I'd like to turn it over to JoAnn Volk from Georgetown University. JoAnn?
Thank you. I'm going to talk first about the objectives of this particular webinar this evening on essential health benefits. Overall, we want to provide you with an understanding of this important part of health reform, what it means, how it came to be, and what needs to happen. That will include an overview of the law on this particular provision, as well as some guidance we've received now from the federal agency in charge of implementing this, the Health and Human Services Department. So you will get all the sort of background details on this, but we also want to, in that final bullet, outline some concerns that we have for patients and how this particular provision, how it gets defined, may create some problems for you unless you get involved and help make it happen in a positive way. All right. Now, just to start us off at the beginning point here, I wanted to remind everyone of the goals of the Affordable Care Act. Now, there's been a lot said about the new health reform law, and we're coming up on a critical period here with the anniversary and the Supreme Court considering the constitutionality of the law. But I just wanted to focus for a few minutes on three main goals of the Affordable Care Act and how they'll affect what we're talking about here tonight. One goal is to improve health coverage for those who currently have it. So despite the high rate of uninsured in this country, the fact remains that most people do have insurance, and it doesn't always work for them the way it should when they need care. It may cut off benefits when they need them most. It may exclude coverage for the conditions they have when they enroll in the plan, or other restrictions that make it difficult to get the care they need even though they have health insurance. And in fact, we know that 50% of the personal bankruptcies in this country are due to medical costs, and most of those people had health insurance. So clearly having health insurance doesn't guarantee that you're protected from financial constraints for getting the care you need. A second goal is to improve health care quality, and that's going to be done through changes in how health care is delivered and paid for, so largely to reward instead keeping people healthy and meeting certain goals for quality rather than rewarding volume and paying for every test and procedure. So the more done, the more providers get paid. And finally, to expand coverage to those without insurance. And this particular law will reduce the number of uninsured by 32 million. Just to focus for a minute, though, on that first part about improving coverage for those who currently have it. There are a number of reforms that went into effect immediately when the law was signed in March 2010. Those include expanding coverage to dependents up to age 26, so you can stay in your parents' plan longer than was typically allowed at this, until now, to prohibit lifetime limits immediately so that your benefits can't run out because you've hit a lifetime limit on how much the plan will pay, and to set limits on how much annual limits can be applied in this first few years. And finally, to put limits on how insurers treat enrollees, so they can't rescind policies, they can't cancel policies once you're enrolled because they find that you have made a mistake on your insurance policy application. And then there are another set of reforms, most of them actually, that go into effect in 2014. So there'll be no annual limits allowed in 2014. There's new rules for how insurers can set premiums based on your age. They can no longer set premiums based on health status. They can no longer deny coverage to those with pre-existing conditions. And it sets a new standard for coverage that is sold to individuals and small businesses. That is essential health benefits that we will be talking about tonight. And it's important to remember that all these improvements I just mentioned apply to coverage in the exchanges as well as outside, whether you're buying an individual policy or small employer plan outside the exchanges. Okay. Essential health benefits and health reform actually addresses two of the three main goals I just mentioned. It will help expand coverage to those without and improve it for those who do have it. How does it do this? As I mentioned, even for people who do have coverage now, often it isn't adequate to meet their needs, their health care needs. So this will set a minimum standard. It will also provide more uniform benefits so it's easier to compare plans and understand what you're getting before it's too late. Too many times people enroll in plans thinking they're going to have coverage for the health care they need, and it's only once they submit a claim that they realize it's not covered. And it's also going to protect against what we call adverse selection, which is where insurers use benefit design or other tools they may have, how they set their premiums to discourage sick people from enrolling in their plans and encourage only healthy people from enrolling. In 2014, we're taking away two of those main goals, setting premiums based on how sick you are or outright denying coverage for your pre-existing conditions. So, for example, offering a plan to cover everything but your circulatory system if you have heart disease. So those tools will be taken away in 2014. What they will have left is benefit design, how they cover services to encourage only healthy people to enroll. So this becomes a very important piece to focus on. So the Affordable Care Act really only has very broad categories for what the essential health benefits must include. It lists 10 categories of services that you see listed here on this slide that must be covered in any essential health benefits package. And these services then were to be further defined in greater detail so everyone could understand what they actually meant. But these categories here don't necessarily align well with what you may see in your current description of benefits and services in your own plan. So for example, ambulatory patient services can cover everything from a routine doctor visit to a home health visit. And obviously, doc visits are much more, as I said, routine, and everybody will use that at some point in the year likely. Home health visits are something that really only sicker individuals are likely to use, but that one category description there covers that full range of services. The other is habilitative services. You see here rehabilitative and habilitative services and devices as one of the 10 categories. Habilitative services is something that's not typically seen in coverage today. Rehabilitative services certainly, but habilitative services is a different matter. It's not just restoring function, it's helping people gain function that they didn't originally have. Of all the categories listed here, there are probably 3 that are going to be most directly affecting the care that you get and we can focus on: ambulatory patient services, prescription drugs, and preventive and wellness and chronic disease management services. In addition to those 10 categories, there are a few more requirements in the law about how to establish an essential health benefits package. The law says that the EHB should be similar to a typical employer plan. And we will talk about later when there was an official look at what that might be. There is no typical employer plan. They vary greatly out there depending on where they are offered industry and the size of the employer and so forth. This new requirement will apply to all new plans sold in the individual and small group market. So for small employers and individuals buying policies on their own, whether those plans will be purchased in an exchange or outside the exchange. It does not apply to large group plans, large employer plans, something known as self-insured plans, which are plans that don't have to meet state requirements. They often cover many states, or so-called grandfather plans. These are plans that were in existence at the time the law was signed and can avoid some requirements such as the Essential Health Benefits Plan until they age out and become new plans. The law's limits on out-of-pocket costs and the prohibition against the annual and lifetime limits that we talked about only apply to benefits included in the Essential Health Benefits package. So if a service or benefit is in that package and makes the definition, the out-of-pocket costs that any patient will have to pay over the course of a year will be capped at about $6,000 for an individual and $12,000 for a family plan. And there can be no annual or lifetime limits for any of those benefits. If a benefit or service is outside that definition, those protections do not apply. And then I just want to finally note that essential health benefits, as we talk about them here, only include the services and benefits to be covered. It does not address what patients will pay out of pocket for those benefits and services in detail. So if you think about your own plan description you might get from an employer during open enrollment, you look at both the services and benefits covered, but also how much cost sharing you might have, the co-pays, the premium, the deductible, if there's any co-insurance, like 20% of all costs above $100. That latter piece, how much you pay out of pocket, those details are not part of this definition. We'll talk about what the rule says about that a little bit later. There are other requirements in the law for establishing the Essential Health Benefits package, mostly around how to actually define it, the process for doing so. So these 4 protections are listed in the law. There has to be an appropriate balance across the categories so that you don't end up with a benefit that's better suited to healthy patients rather than sick patients. It can't result in discrimination against individuals because of their age, disability, or expected length of life. It has to meet the healthcare needs of a diverse segments of the population, and once it's established, no benefit within that package can be denied because of a patient's age, expected length of life, a disability, or a degree of medical dependency or quality of life. So these are sort of broad protections, but nonetheless really address this notion that the Essential Health Benefits package must be balanced and meet diverse needs and not be something that only healthy people will find benefiting them. Now, one more set of requirements in the law has to do with additional protections once that essential health benefits package is actually defined. HHS must review these benefits periodically and make sure that they are meeting the needs that they are supposed to meet. So, for example, if patients are having difficulty accessing needed care because of how this is defined, because either the cost of the coverage or it's simply not covered at all, it must be updated if it's become out of date to include medical advances or scientific advances. If a new treatment was discovered, or new prescription drug, that must be taken into account and incorporated into the essential health benefits. This should not be a package that does not change over time to meet changing needs. And then they must also consider adding benefits to the essential health benefits package would increase costs or affect the actuarial value. There's that term we'll talk about in a little bit, but it's how much the plan will pay of a typical patient's costs versus what the patient would have to pay. And I guess I would describe this by thinking of the benefits as sort of a balloon in a box. If you think of all healthcare services as the balloon and you're fitting into a box that is the essential health benefits package, if you try to add more air to that balloon or more services, something's got to give. That balloon won't fit in that box any longer unless you release air or drop some services from somewhere else. So it's a sort of defined universe here that you can't just keep adding services and expect that the constraints for cost will still be met. Okay, there we go. All right, now finally this topic of actuarial value and the cost sharing that I said we would get to. Here it is. And I will go through it here, but I just want to warn that this is a complicated topic. It's going to come up regularly as you talk about the Affordable Care Act in your state, so we wanted to make sure you had some understanding of it. But there's also a very good definition in that glossary that Larry mentioned in the beginning as part of the materials shared with you in advance of this webinar. So this issue of cost sharing, it's how much someone will pay out of pocket in their deductible. So set aside the notion of the premium. It's once you're enrolled in the plan, what can you expect to pay for services? The deductible you have to meet, the co-pays you have to pay for different visits or prescription drugs, or even something called co-insurance, which is to say the share of costs you have to bear. This is sometimes with specialty drugs or other hospital services, where it's your costs are a share like 20% of all costs above $100 or something like that. So actuarial value is a measure of the cost sharing that an enrollee has in a plan. There are 4 tiers of coverage in the Affordable Care Act based on this measure: a bronze, silver, gold, and platinum plan. This is this notion of standardizing plans so that there's not infinite varieties of benefits, that they fall into one of these 4 categories depending on how generous or comprehensive the plan is in terms of the costs that cover. The actuarial value is a measure of how much a typical patient might pay in the course of a year. If you think about the average healthcare cost of any patient over the course of the year, if the plan is a bronze plan, it will pay 60% of all those charges over the course of the year, and the patient will be responsible for 40% through all kinds of cost sharing, whether it's the deductible or co-pays or this co-insurance. The more generous plan, the platinum plan, would cover 90% of those costs. This does not tell you how much is going to be paid for any particular service. Within the package and individual services, there might be some services that require 0 cost sharing, for example, preventive services, and other services that require 100% cost sharing from the patient. But this is an average across the full year and all plan services. So a little bit about how the benefits were set, or how the Department of Health and Human Services has gone about defining the essential health benefits beyond those very broad parameters in the law. The Department of Labor did a study of this typical employer plan, as I said, is mentioned in the law. And it turns out it wasn't all that useful. They, in their study, looked at employer plans, those large employer plans like an IBM that has employees in a bunch of different states and set their benefits their benefits according to whatever they consider appropriate and not according to state law. And then for others, they looked at state-regulated benefits. In every state, there are a set of rules that set benefit requirements for health plans sold to small employers and individuals, and these may require coverage for things like in vitro fertilization, diabetes care, maternity benefits, or autism, and these are known as state mandates. The Department of Labor study looked at the typical employer plan and looked at all of those and tried to establish what a typical employer plan might be, and found that it was hard to define that. There is no one magic plan out there that is representative of all. The Institute of Medicine also did a report. This is an academic, nonpartisan group that Congress often turns to for study of complex issues. And the Institute of Medicine was asked to make a recommendation on the process, not the exact package, but how HHS might go about defining this package. And there were two real themes in their report that I think are useful for you to hear tonight. One is that they were dismissive of this notion of state mandates. There may be many services that you all rely on that are not there because of state mandates. For other patients, that is the case, like people with diabetes. So that was a troubling finding or recommendation for many patient groups out there. And then they also suggested that the starting point for HHS be a premium target. So pick the amount that you might want to pay, how much small employers pay now, for example, and then figure out how many benefits you can back into that cost. That is a very different process from sort of looking at the benefits holistically and saying, what do people need to get the care they need? And it could have been really troubling. That might have left out a lot of needed services and treatments because they were trying to fit it into a particular premium target. And then HHS held listening sessions with consumers, providers, employers, and health plans, insurers, in Washington, D.C., but also some across the country. And there were representatives for many of your organizations that participated in some of those listening sessions and offered some initial feedback on how this might be designed to help your patients. So how did we get here with this state-based approach that you might have heard about, and I'll explain more, when everyone expected the HHS to come up with a federal definition of essential health benefits package? With the recommendations of the IOM and the Department of Labor study, everyone expected the Department of Health and Human Services to just sort of detail those 10 categories and say to insurers, this is what you must offer in every state to every small business and individual who wants to buy coverage from you. That was not the case. We instead have this state-based approach where each state will establish their own essential health benefits package. And I want to talk a little bit about how we got there. HHS did their own study of benefits currently offered to small businesses, state employees, and federal employees, and found that the plans were largely similar in the benefits that they offered. So if you just look at the categories of benefits and thinking about those 10 categories, there was a lot of similarity across plans. There were a few exceptions. So for example, some benefits that are covered only because of state laws, and those would be the in vitro fertilization and certain treatments for autism. Were not typical across all plans. They were sometimes only seen where states required plans to cover them. And then there are a set of services covered in plans that don't have to comply with those state insurance laws, offered voluntarily and not uniformly across all those different plans. These include mental health and substance abuse services, pediatric vision and oral services, and this habilitative services that we talked about earlier. Where they did see differences between plans was not in the services covered, but in how much patients would have to pay out of pocket. So the variety might be in the deductible they'd be subject to, or the copay for a doctor visit, and not that it covered a doctor visit. That was uniform across all plans. So what did HHS propose in this, this guidance they offered officially in December of last year? They gave the states the option of choosing from among 10 plans that are currently in their state. Those offered to small businesses, so any of the 3 largest plans offered to small businesses, a small group market. Any of the 3 largest state employee plans, any of the 3 largest federal employee plans, which I will just say is the same 3 across all states. There's national plans offered by Blue Cross Blue Shield Association. And then the largest insured commercial non-Medicaid HMO. A lot of states have, as you know, Medicaid-run HMOs or contract HMOs under the Medicaid program. This is not those. This is non-Medicaid HMOs offered in the commercial market. These existing plans, known as benchmark plans or options, include not just services and treatments covered, but also any limits that they may apply to those services and treatments. So, for example, visit limits. HHS said when you look at those plan options, you get to list not only the benefits and treatments covered to define the 10 categories, but any limits that they may have in their plan. So a little more on the HHS proposal. They said once the state looks at those 10 options, if a benchmark they choose doesn't cover all 10 categories that are required under the ACA, that list we looked at much earlier, then benefits must be added so that each of those 10 categories is covered. If a benchmark doesn't include coverage required by their state law, these state-mandated benefits, a state can add it to their essential health benefits package, but at a cost to the state for those in the qualified health plans, the exchange plans. And this was part of the federal law. This is something that carries from the federal law, not just what HHS says. They said that if the essential health benefits package, especially if it was defined by the federal government, did not include some services that would be required by a state under their law, the state could say in their state the essential health benefits package had to include those benefits, but they would have to defray the cost for people enrolled in those plans in the exchange, whether they qualify for a subsidy or not. And that would have been a big barrier to states incorporating additional services in their essential health benefits package because they simply don't have the budgets right now to pay for extra services. And then if a state does not choose an essential health benefits package, the default plan will be the largest plan by enrollment and the largest product in the small group market. These are sort of technical terms that essentially boils down to the largest small employer plan. There are a few more pieces to note in the guidance from the Health and Human Services. They suggest that insurers can have flexibility to offer benefits that are similar to, but not exactly the same as the essential health benefits option that the state chooses. They may do substitutions of coverage within a category, changing actual services covered and any visit limits. They may do substitutions across the 10 categories. And the only limits that HHS suggested might apply to this flexibility is that they have to have roughly the same actuarial value, the same share of costs covered by the plan as the benchmark. I want to give you some examples of what some of those substitutions might be. HHS gave this particular example when they were describing their approach. Within rehabilitative and habilitative services, that might include, in the benchmark plan, 10 occupational therapy visits, 15 physical therapy visits, and 20 speech and language visits. An insurer would have the flexibility to change that up and say, we will allow 15 occupational therapy visits, 10 PT, and no speech, so long as the overall value of those benefits was about the same as what the benchmark did. And then within the ambulatory patient services, we talked about how that can include everything from a routine doctor visit to a more serious or costly home health visit. They could change around the visit limits that might apply to those services, and so long as the value was roughly the same, they would be allowed to make those substitutions. But obviously, depending on how that gets defined, might not be all that helpful to someone who has more serious or chronic care needs. And then the other flexibility offered to insurers in the bulletin is the flexibility to offer a prescription drug benefit that is lower than the essential health benefits benchmark. They said in the bulletin insurers could offer just one or more per class rather than two or more. They said that they were going to try to meet the Medicare standard, but in fact Medicare requires two or more, and many plans out there now that people buy have many more drugs per class covered. So this flexibility was especially problematic because it would have allowed them to get away, insurers to get away with covering just one drug per class, which could be really make coverage for many people inadequate. I think we've also had a report that some among your advocates heard from the National Health Council that HHS has heard so much criticism of this notion of the Medicare or the prescription benefit flexibility that they're backing off of that now and saying they would have to offer at least two or more recognizing that what's typically done in the market now is much more than one. Okay, so I just wanted to go through, now that you've heard what HHS has proposed for states picking that essential health benefit package for their small employers and individuals buying coverage, I want to go through some areas where it falls short on process to begin for picking the essential health benefits package. Getting the information on those 10 benchmark plans will be difficult. Not every state collects enrollment data for their small employer plans and so can't identify their top 3. HHS released a list of the top 3 plans based on some data they received last year when they were building their healthcare.gov website, but it's based on data from last year, and states need to make some decisions this year based on enrollment data this year. So some states have already said that the list they got from HHS is outdated and they have a different set of 3 high enrollment plans than what HHS indicated. And then just knowing which plans make that list of top 10 options doesn't tell you enough. You really need to know what the plans actually cover to understand what the essential health benefits plan might be in your state. And for that, you really need detailed plan documents, not the very general summaries that employees often get with their open enrollment period. By tracking it to what the coverage that's currently offered in each state, it means that the essential health benefits can change as the benchmarks change. This is a very different, I mentioned before that this is not intended to be a static package of benefits. It is intended to change, but the changes outlined in the Affordable Care Act have more to do with making sure you're closing gaps in coverage that emerge or are shown once this package is being used, or to update it to reflect medical advancements. That is different from just tracking how the market changes for reasons that may not have much to do with access to care and affordability. It's unclear where the decision will actually be made in the states. It might require legislation in some states. It might be something that the executive can do, the governor with an executive order, or it may just require the Department of Insurance to release some proposed guidelines of their own. It will vary from state to state. And then finally, enforcement becomes a really big concern. Those protections I talked about earlier with making sure that it was balanced and doesn't discriminate against people based on disability or age, that enforcement will fall to the states now to make sure that the plans meet those requirements. And that becomes an even more difficult task if insurers are allowed flexibility to take the benchmark option and change it around in the plans that they actually offer to patients. So where the proposal falls short on the package we actually get out of the process, it weakens the key goals of the essential health benefit package. Those 2 goals, to set a minimum standard for coverage. Obviously, if there's not just one federal standard, there's 50 standards or more. We certainly have 50 standards with each of the states choosing their own option, but within the state there might be variations on that with the insurer flexibility to move things around. So it's hard to say that you've established a minimum standard of coverage with that much flexibility and variation. It also makes it harder for patients to compare plans, to do the apples-to-apples comparison of plans, to really choose the plan based on the network or the premium. There will be potentially many other differences to consider when looking at your options. It also gives back to insurers this flexibility to use benefit design to avoid the sick, especially with those other 2014 reforms I talked about, the prohibition on insurers denying sick people coverage or charging them more based on their health. It creates more confusion and uncertainty for consumers, and the prescription benefit requirement, as it's in the bulletin now, as I said, is not as strong as Medicare or the coverage that currently exists in the private market. So what can state advocates do in this early part, these months that follow HHS releasing this proposal through to the fall, when states are supposed to be selecting their essential health benefits package to be sold in their state markets beginning in 2014, both in the regular market as well as in the exchanges? Well, I would say the first key thing to do is for advocates to ask their states to use a transparent process to choose their essential health benefits package. We know from some of the research we've done here at Georgetown that some of the states have begun this process, and in many cases that's really just now some sort of informal meetings with departments of insurance looking at some of the options and thinking about what they might do. It's not an open process. It's not including, in many cases, opportunities for consumers and patients to offer their suggestions or concerns. So they should definitely establish a transparent process that both makes clear the factors that the state will use in making their choice. That may be a balance among the categories. It may be comprehensiveness. It may be the right cost. It may be to minimize disruption, so things look as much like the coverage available now, but to make those factors clear, and then to allow for public input, whether it's official hearings or open meetings or whatever it might be, to make publicly available the plan documents for each of those benchmark options. So as I said, not just knowing what the 10 plans are, but what they actually cover in detail in services and benefits and any limits they may apply, and then ensure enforcement of patient protections and other federal law requirements once the benefit is, as it's being selected and once it's being enforced. Additionally, what advocates can do now is engage your allies if the key decision makers aren't being responsive to your needs and requests, that these continue to be sort of closed-door, informal meetings where patients and their advocates are not allowed in or to even understand what's being discussed. Rope in a friendly legislator, state legislator who you've worked with in the past, or find a Medicaid agency person you've worked with and have them help you sort of flesh out where things are happening and how the decisions will be made so you can jump in and offer your concerns or interests. Other patient groups are making many of the same requests as you may. If you follow this suggestion, they too are asking, what are those 10 plan options in our state and what do they cover? And as I said, you really can rope in a friendly legislator to figure out where things are being, where decisions are being made. And then importantly, provide feedback to your national chapters and organizations to help identify the best practices and successful approaches. There may be things that you're dealing with that the national chapters with your sponsors and others can help you find the best way to address. And it may be that what you're dealing with in your state is happening in many other states too, and we can identify some best practices or a good successful line of attack, either to get the information out there or weigh in with your concerns. And that is the presentation for this evening. We'll be happy to take some questions about the presentation.
And so this is Michelle Rice from the National Hemophilia Foundation. We want to thank you for attending today's webinar, and also to remind you that a recording of the webinar will be available on the website of the national organizations referenced earlier in this presentation, along with copies of questions and answers that we received this evening. So again, thank you for joining. We look forward to you participating in our next presentation. Good night.